Today we will be discussing about febrile seizure. We will discuss this topic simply under these four subheadings. Definition, what is the epidemiology and what are the facts related to febrile seizures, how do we disk analysis this case, and how do we approach a case of febrile seizure. So coming to the definition, febrile seizure means seizure that is occurring associated with fever. That makes temperature of more than 100.4 degree Fahrenheit a mandatory criteria to label it as febrile seizure. So does that mean that only after fever seizure can occur? No, that is not true. Some studies have shown that fever can occur even before, after, or during the episode of seizure. But most commonly what we see is febrile seizure occurring within 24 hours of fever onset. Next is the age criteria. It occurs between 6 months to 6 years of age, peaks at 18 months of age. So does that again mean that it cannot occur below 6 months or it cannot occur more than 6 years? No, that is again not true. NIH has told that it can occur up to 3 months and even ILAE has told that even 1 month baby can have a febrile seizure episode, provided we rule out every other cause. So can it happen after 6 years? Yes, that is what we call febrile seizure plus, which we will be seeing in some time. We must also think what are the other causes of seizure that we must rule out. So apart from febrile seizure, what are the other 3 common causes of seizure? First is CNS infection. Second thing is if there is any metabolic abnormality, and if there is any acute neurological insult like trauma or head injury that we have to rule out to label it as febrile seizure. You must know what is simple and what is complex febrile seizure. Simple febrile seizure means it is a GTCS type of seizure that is occurring less than 15 minutes and there is no recurrence in 24 hours. If any one of these is present, then it is complex. So simply remember, febrile seizure never focal, never more than 15 minutes and never recur within 24 hours. If any one of these is present, then it becomes complex febrile seizure. Then what is febrile status epilepticus? It is based on the duration for which seizure is occurring. If it is more than 30 minutes, then it is febrile status epilepticus. Next is febrile seizure plus. This is more than 6 years or afebrile GTCS or focal seizure. Plus here means 2 deviations. It can be either that it is more than 6 years or it can be also that it is afebrile GTCS or focal seizure. Then what is genetic epilepsy with febrile seizure plus? If there is febrile seizure plus and there is a history of either febrile seizure plus or a febrile seizure, it comes under genetic epilepsy with febrile seizure plus. This is the same thing, definitions, which is adopted as per ACOM consensus. Then one more thing, what is FIRS? Febrile infection related refractory epilepsy syndrome, which is nothing but FIRS. So what are the characteristic points that we must remember is that it is predominantly in older children more than 5 years of age, male predominant, associated with encephalitis-like features, but there is no identifiable infectious agent. These children are previously normal, but they develop a difficult to treat epilepsy. Next, coming to the approach. Like any other case, we would like to first take the history, examine the patient, and then go for management. So taking a quick history, what all things we will ask? So febrile seizure, we will ask about the seizure. What is the nature and duration of convulsions? Then we will ask why fever has occurred. Most common cause of the fever, maybe it is AOM, acute otitis media, or any respiratory complaints. And we have to ask immunization history. Why? Because some vaccines are prone to cause febrile seizures like MMR or MMRV. Then coming to the past history, if there is any similar attacks in the past or any other neurological diseases or history of NICU stay for HIE. And we will ask family history of seizure, epilepsy or any neurological disorders. And we will take developmental history and look if there is any delay in the developmental milestone. Next, coming to the examination, we will see basic vitals, if there is any temperature and tachycardia, if there are any features of raised ICP or any meningeal irritation or nuchal rigidity or focal neurological signs. Then we will manage acute febrile seizure. We will give medications to abort the seizure, and acute illness means fever we will control. Like we will give first aid with midazolam, diazepam, and we do the initial diagnostic tests as needed. Next, coming to determining the risk factors and recurrence and also estimate the risk of recurrence in febrile seizures. After this, we will counsel the parents accordingly. So what did we learn in our first aid? That first we will manage the seizure. If the child is at home, then we will train the parents to give intranasal midazolam, abortive medication for the seizure. This is most commonly used route of drug administration rather than IV or per rectal diazepam. Next, you have to manage the fever. This is not to reduce the occurrence or recurrence of the fever, it is just to comfort the child. And then we ask the parents to take the child to hospital immediately. Now we have to determine the risk of recurrence. There are 2 classifications, major and minor. What are the major risk factors? If the age is less than 1 year, duration is less than 1 day, and fever is between 100.4 to 1 or 2. What are the minor risk factors? There is family history of either febrile seizure or epilepsy, or it is a complex febrile seizure. Child is in daycare, is a male child, and there is lower serum sodium at time of presentation. How we will know the percentage of risk of recurrence? If there is no risk factor, then also risk for recurrence is 12%. If there is 1, it will double, 24 to 25%. Again, if there are 2 risk factors, then again it will double, 50%. More than or equal to 3, it is 75 to 100%. So how we will remember this? If there are no risk factor, it is 12. If there is 1, then it will double to 24 to 25. If there are 2, then again it will double to 50. If there are more than or equal to 3, then again it will double to 75 or 100%. With each increasing risk factor, the percentage doubles. So these are some key points from Nelson that we must know. So why does this febrile seizure occur? What is the relation between fever and seizure? So basically there is an immune dysregulation and there is increased in pro-inflammatory state or pro-inflammatory markers, and there will be decreased anti-inflammatory marker, creating a pro-inflammatory state of the body. What are the pro-inflammatory factors or cytokines? Interleukin 1 beta, interleukin 6, interleukin 8. And what are the anti-inflammatory that will decrease is ILR1A. So if we consider the ratio between anti-inflammatory ILR1A and IL8, which is a pro-inflammatory marker, overall it will decrease in febrile status epilepticus, which is also a potential biomarker to estimate the febrile status epilepticus. So what next? We definitely ask about the family history. So we tend to imagine that it is an autosomal dominant condition, but inheritance is mostly polygenic rather than autosomal dominant. So what are the genes associated with febrile seizure? It is SCN1A, 1B, 9A and CPA6. What is the relation between infection and febrile seizure? So viral infection HHV6 tends to lead to febrile seizures more than HHV7. And we have already seen that low sodium levels is a risk factor for the recurrence of febrile seizure. Next, coming to determining the risk for later epilepsy. How we will remember this? So simple febrile seizure is 1. Simple is single. So 1. Only 1% of subsequent epilepsy risk in simple febrile seizure. Next, coming to recurrent febrile seizure. Recurrent 4. Recurrent is 4. Next, complex febrile seizure. Complex is 6. So 6%. But this complex febrile seizure, we have 3 criteria. Either it is focal, or it is more than 15 minutes, or it is recurrent within 24 hours. So the last 2 will fit into this 6 wala criteria. Means more than 15 minutes and recurrent within 24 hours. If it is focal, then what? Then we will see in few seconds. Now coming to fever less than 1 hour before febrile seizure. Less than 1 hour, 1 we will take and again write 1. So it is 11%. Okay. So we have seen simple febrile seizure, we have seen recurrent febrile seizure, we have seen complex febrile seizure and febrile seizure less than 1 hour within the fever onset. So it is 1, 4, 6 and 11. Next, coming to family history of epilepsy. It is 18. It is family, it runs in family, and family is never ending, like infinite. So it is 18. Complex febrile seizure of focal origin. This we have seen 28. How do we remember this? So you can also write F as 8. So it is 28. Next, coming to neurodevelopmental abnormalities. So neurodevelopmental. E looks like 3. So it is 33. So again, coming to the risk for subsequent epilepsy. So in case of single, it is simple, means 1%. In case of recurrent, it is 4, means 4%. In case of complex febrile seizure, we make it 6, it is 6%. Febrile seizure less than 1 hour of onset of fever, it is 1 and 1, 11%. Next, coming to family history of epilepsy, family is never ending, that is infinite, that is 8, that is 18%. Next, coming to complex febrile seizure, which is focal, F we are writing as 8, that is 28%. Then neurodevelopmental abnormalities. We are writing neurodevelopmental. E looks like 3, so it is 33%. More than one risk factor is additive. If there is low risk or high risk, we do our investigations and treatment accordingly. In case of low risk cases, there is no therapy or investigation that is needed. In high risk cases, you have to consider EEG imaging and you have to consider intermittent prophylaxis or continuous prophylaxis that we will see now. What investigations to do? In case of first episode of simple febrile seizure, there is no need of doing any heavy investigations if the child is stable and is not sick looking. But if there is any features of meningitis, the child is sick looking and high risk patient, then you have to go for investigations. So when will you do CBC, CRP, blood sugar and serum electrolytes, means including sodium, potassium and calcium? So you do it in complex febrile seizure and febrile status epilepticus. Calcium, definitely in complex febrile seizure, febrile status epilepticus. Apart from that, in less than 1 year of age in simple febrile seizure also. Serum iron profile, is it required? In case of iron deficiency anemia, there is a risk for developing febrile seizure, but we usually don't do serum iron profile if the child is not clinically pale. So if there is pallor, then only we will do, otherwise it is not indicated. When we will do urine profile. So we know that in case of less than 18 months children, it is one of the most commonest cause of fever. So if we are not seeing any focus in less than 18-month old, then we will do urine profile. In case of more than 18 months old, if there are symptoms, then only it is indicated. Next, coming to three main investigations that we do in case of seizure attack. So one is EEG, lumbar puncture, or neuroimaging. Coming to EEG, we have to take 30-minute recording both in sleep and awake state. And whom to do? In case of complex febrile seizure, within 1 week or as early as possible we do. Or if there is any focal findings on neuroimaging. But this EEG do not predict future recurrence of febrile seizure or epilepsy even if it is abnormal. When we will do lumbar puncture, so first is febrile status epilepticus, or if there is any signs of meningitis. And if we are doing CSF analysis and it is a proven meningitis, then we have to send meningitis panel. In case of first episode of febrile seizure in a less than 1 year old who is not vaccinated with pneumococcal and Hib, we have to do a lumbar puncture. In case of more than 1 year, if the child is already pre-treated with antibiotics, then it is indicated. One more indication is when there is prolonged abdentation after benzodiazepine. There is delayed regain of consciousness to baseline after benzodiazepine is a clear indication of LP. Then when we will do neuroimaging, CT or MRI is to be done based on suspicion in case of complex febrile seizure. So first episode of complex febrile seizure with prolonged or focal findings, we have to do MRI within 72 hours. Next, in all cases of complex febrile seizure, should we do a LP? No, it is not required. Then in case of 12 to 18-month-old and vaccinated child with no features of meningitis, then what we will do? Then also LP is not required. When do we do neuroimaging before a lumbar puncture? Definitely in case of any raised ICP. So if a prior neuroimaging has been done and it has not shown any alternate diagnosis, then is there an indication to repeat it? No. There is no indication to repeat a neuroimaging in the follow-up if previous is normal. Then what about genetic test? When should we do genetic test? So if we are suspecting a Dravet syndrome, means in case of recurrent febrile status epilepticus, onset of prolonged hemiconvulsive seizures less than 1 year of age, then we will go for genetic testing. Coming to the management, there are three side headings. What the parents will do at home, should we give intermittent prophylaxis, and what is continuous prophylaxis, when should we give? So first thing is, if a child is having febrile seizure at home, then we will give abortive medication. What abortive medication do we give? It is intranasal midazolam. How much do we give? 0.2 mg per kg. So as per book, it should be started after 3 to 5 minutes of seizure. If it is not subsiding on its own, then we will give abortive medication. But in practice, because of the parents' panic, we immediately recommend intranasal midazolam. So what if the seizure does not subside even with 1 dose of intranasal midazolam? Then we can repeat the dose after 5 minutes. Next is when to repeat. We have seen when to bring the child to hospital. So if there is any complex febrile seizure, means there is recurrence or more than 15 minutes or focal episode, and age of the child is less than 6 months or more than 6 years. Next, if age of the child is less than 6 months or more than 6 years, or the child is having any neurodevelopmental abnormalities, or the child is not gaining consciousness after the midazolam, if the child is sick looking or having any CNS infection, or if the child is having any general danger signs, or the hospital is far away from their home, then also we can advise them to bring to hospital immediately. Then we have to give antipyretic, and we have to educate about recovery position. Recovery position means the child is turned to one side with the head tilted away, and the airway must be ensured to be open, and hand is placed in support to the head. One leg is bent so that there is no rolling over. Next is intermittent prophylaxis. Whom to give? In case of frequent simple febrile seizure where the parents are very anxious, if the residence is far from a medical center, if a complex febrile seizure is not qualified to get a continuous prophylaxis, then we can give them intermittent prophylaxis. Then what to give in intermittent prophylaxis is clobazam, nothing but frisium by the brand name. So how much to give? 0.5 to 1 mg per kg per day. This we have to give in 2 divided doses and for 3 days, and maximum dose being 20 mg per day. What we have to note here is that intermittent prophylaxis is not recommended in first episode of simple febrile seizure. What is continuous prophylaxis? Whom to give? In case of febrile status epilepticus, frequent complex febrile seizures, or is a known case of neurodevelopmental delay, and children with febrile seizure plus or genetic epilepsy febrile seizure plus with afebrile seizures. These are the candidates qualifying for continuous prophylaxis. So what to give in continuous prophylaxis? Sodium valproate. So sodium valproate is a hepatotoxic drug. So should we do ILFT before prescribing valproate? Not required in a otherwise healthy child. So how long to continue? Once initiated, it must be continued for at least 2 years. If it is a genetic epilepsy, febrile seizure plus, or we are suspecting a Dravet syndrome, then we will manage as per the case. So what we must remember in this case that we should not do. First thing is, don't give sodium valproate if you are suspecting a IEM case. In case of Dravet syndrome or febrile seizure plus or genetic epilepsy with febrile seizure plus, sodium channel blocker means phenytoin should be avoided. Coming to the last and most important part of our discussion, parent education and counseling. What should we cover in this aspect? First thing is you should explain why febrile seizure occur and they do not constitute epilepsy. You have to explain then the risk of epilepsy. Next is risk of death is negligible in this febrile seizures. Simple febrile seizure do not lead to epilepsy or intellectual impairment. You have to explain about the risk of febrile seizure recurrence and what should be done if the child is having fever or if the child is having seizure at home. First aid should be explained. Recovery position should be taught. What is rescue medication and how do you give it? You also have to explain the danger signs and when to bring this child to hospital. I hope this session was useful. Please do comment below if you have any doubts. Let us